Thank you for the opportunity to address the committee this morning and to participate in this important process. The American Association of Oral and Maxillofacial Surgeons welcomes the interest and support of the Academies, not to mention the NIH, NIDCR, the Food and Drug Administration, and the TMJ Association in this collaborative effort to improve the care we deliver. I have little time, so I'm not going to say nearly as much as I would like to the issues that I've been asked to address, or to the patients represented here whose contribution to this effort has already been so deservedly applauded. Most of us have met before, and I've heard your stories before, but they are no less difficult than the first time, and perhaps more powerful, because it may have been 3 or 4 years now since that first time, but that drives home the fact that in the interim, you've continued to suffer. To someone like me who has spent almost 30 years working very hard to improve people's TMJ problems and train others to do the same, this is a difficult and emotional issue to be confronted by. So thank you again, and to each of you, I say I'm sorry. I'm sorry that you continue to suffer, that we failed in our promise to make you better, not worse. I'm sorry you heard foolish, ignorant, dismissive, carelessly cruel things from those who were supposed to care for you more than when you really needed it the most. I'm sorry that you've had far more operations than any one person should ever have, or that you very understandably don't know who to trust. We can point to our many successes, and they are many, but that provides no comfort at all to those of you whom we failed. I think it's our job now to see how we can shrink your numbers as close to zero as humanly possible. So thank you again for pushing us all together. So, to get to work here, I need to frame discussion of care pathways by briefly touching again on the definition of TMD. What I've taught dental students for a long time now is that TMDs are a collection of unrelated diseases sharing the common symptom of orofacial pain. That pain generally drives patients to their dentist, either first or at the direction of their primary care physician. That is, in fact, a good place to start because a properly trained dentist should be able to at least distinguish joint disease from extra-articular disease and provide initial care. 2 points on this. 1, good training cannot be assumed, and this should be addressed. We've heard plenty of evidence of that over the last day. Stronger predoctoral dental accreditation standards are one avenue to explore. Dr. Frickton yesterday mentioned specialty recognition as a second means to improve predoctoral indication, specialty recognition for orofacial pain. I would look at how well that strategy has worked for other nascent dental specialties and improving their visibility in the predoctoral curriculum. Second point, good fare is founded on a good diagnosis. TMD is not a diagnosis. A patient may have one or more TMDs and perhaps highly relevant comorbidities, but they can't just have TMD. For sure, they can't have TMJ, any more than an orthopedic surgeon would tell someone they have knee. I realize this makes me a splitter, not a lumper, and that examining TMDs collectively has been useful, but that utility breaks down when you're attempting to address the needs of an individual patient. So with these caveats in mind, the general dental point of entry is potentially quite efficient. We should not lose track of the vast majority of TMJ sufferers who have episodic, painful TMJ popping, clicking, perhaps brief locking, and or masticatory myalgia, whose condition resolves totally with nonsteroidals, soft diet, possibly reversible splint therapy, and time. For those who don't resolve, or to co-opt the opera shorthand, those cluster 2 or 3 patients, referral is appropriate. A knowledgeable general dentist can triage that referral to an orofacial pain specialist for non-surgical care or an oral and maxillofacial surgeon if they suspect true joint pathology. To address that surgical care arm, I need to step back once again to the TMD definition. One of the things we've heard over the years, not just here, is that the TMJ is special. And I would argue, well, yes and no. On the one hand, yes, teeth and occlusion are literally attached to this joint, and that gives it some importance in ways that other joints perhaps don't have. It has some unique biological properties that change the way it can heal. You know, fibrocartilage heals much better than the hyaline cartilage that lines other joints. That gives us a competitive advantage. On the other hand, the TMJ gets the same diseases as all other joints: rheumatologic problems, trauma, ankylosis, osteoarthritis, infection. Treatments for those conditions parallel those for other joints, and I think considering them as part of the TMD spectrum may actually muddy our ability to look at the important comorbidities affecting the broader TMD category as we seek to identify those. So those that are not TMDs in the sense that we're using the term really should be addressed separately. Now, there's a gray area in the middle, and that would be perhaps disc disorders. That is typically considered a TMD. Frequently, those disorders are managed non-surgically. Occasionally, there is an indication for surgery. That is an area where we need some intense focus, because that is probably the most controversial part of what we do surgically. Now, to that end, oral and maxillofacial surgery is uniquely positioned to bridge medicine and dentistry because we train in both. We're a highly selective specialty, and we get the luxury of training the best dental graduates, which is in some ways parallel to the orthopedic surgeons. After 4 years of dental school, oral and maxillofacial surgeons will do 4 to 6 years of surgical residency in a hospital, rotating on other services like any other hospital surgical trainee. We produce about 435 new surgeons a year, not all of whom will do TMJ surgery. And that is a two-edged sword. On the one hand, that does limit access to care. But on the other hand, quite honestly, we don't need dabblers. I think we've heard plenty to know that subspecialty expertise is particularly important to this small field. About half of our graduates also are in medical degrees, and that has been stable now for about 25 years. That proportion is not changing and is not likely to in the future. There is no distinction in scope of practice based on the presence or absence of a medical degree within our specialty. We do have a board certification process. It is rigorous, requires ongoing certificate maintenance, which is also evolving much like you see in all medical specialties in these days. So when indicated by a properly rendered diagnosis, we treat TMJ disease with arthrocentesis and arthroscopy, arthroplasty, and by that I mean open joint surgery, or total joint replacement. And we have a robust literature base that supports the safety and efficacy of those procedures, which we can make available to you. So we really should not lump orthopedic disease into the TMDs. And we get referrals for those conditions from the sources you would expect: rheumatology, ENT, dentistry, orthodontics. I would add that we are, as members of the medical and dental communities, well positioned to make appropriate referrals as routinely as possible. When you're in the system, it's easy to just get people farmed out to the other specialists they need to see. But I'm going to look now at some of the challenges we face in doing that. So if you look at our challenges, first, patients who don't get good referrals because their dentist doesn't really know what to do with them, or their primary care physician, they have to go to the internet and wade through quackery. And if you look for TMJ care, you'll see what I'm talking about. Controlling that is going to be very difficult. I would suggest that maybe we heard a parallel yesterday from Dr. Cho, where the AAOS, the American Academy of Orthopedic Surgeons, and NIH defined by consensus what is and is not appropriate, looking at the stem cell transplant issue. We would be happy to be part of a similar partnership, looking at perhaps poorly supported or harmful TMD therapies. Insurance is a problem. 24 states allow exclusion of body parts, and many policies use that to write off anything that has to do with the temporomandibular joint. And you can call a company and say, well, what if they had a cancer in the TMJ? Sometimes they'll say, oh, well, we would cover that. But sometimes they'll say, TMJ is excluded. Really? Fortunately, that doesn't get put to the test very often. My state allows contracts to dictate fees for uncovered services. So we won't pay for a given thing, but we're going to tell you how much you can charge anyway. That's a strong disincentive to participation for the provider. Jennifer yesterday told us about her surgery being denied because it was dental, and that is a common event, particularly with Medicare, because as soon as they hit DDS and the review, they stop right there, don't read any farther, and say, oh, dental, and blanket reject. So we have to reapply. That's a great tactic if you're trying to defer payment or authorization, but it's a complexity we deal with on a daily basis. Participating in insurance panels is more complicated than we could talk about right now. In my state, you could be a Medicaid provider, which I am, but then are you straight Medicaid or part of one of the Medicaid HMOs? And are you a medical or a dental provider for those HMOs? Because for some of them, you can't be both. I don't even know. I have someone in my office who tracks that because I can't remember who I'm a provider for just within state Medicaid. We clearly need a registry for, at a minimum, TMJ implants. The UK has a robust registry. We are working on it, but the small scale of our discipline hurts us. 1.1 million knees and hips are replaced in the US every year, but about 1,800 to 2,000 TMJs. So the cost per unit is simply too high for us to afford a robust registry like the American Joint Replacement Registry for the orthopedic surgeons, given the resources we have presently available. We need validated patient-reported outcomes for our procedures, both large and small. For this, we need input from patients who have done well, and certainly from those who have not. I worry about our ability to communicate with patients. If there was a common thread that hasn't been yet explored among the patient stories we've heard, there were examples in every case of simply abominable communication. I worry about this particularly because we are now training a generation of medical and dental students who have trouble making eye contact except with their phone. So this is not going to get better but worse unless we deal with this as its own issue. There are not enough orofacial pain specialists. And there are even fewer multidisciplinary, interprofessional head and neck pain management programs in the United States. Having a center that can provide tightly collaborative care for the most complex patients involving compassionate, knowledgeable neurologists, oral and maxillofacial surgeons, orofacial pain specialists, physical therapists, pain psychologists, rheumatologists, and perhaps others, is the best means to make the best diagnoses, manage the most difficult problems and comorbidities, coordinate care, reach best possible outcomes for the patients with the hardest problems. This is available to very, very few people, and all too often, other barriers prevent their engagement until it's too late. The fourth question I was asked to address: we disseminate new knowledge through journals, at meetings, special TMJ-focused courses, at the American Society of Temporomandibular Joint Surgeons. To improve this, it's easy. More is always better, of course. And I'm going to stop here. But I want to thank you again for inviting us to collaborate on this very important matter. And the American Association of Oral and Maxillofacial Surgeons is more than willing to continue to engage with the committee as you move forward. Thank you.